So welcome to February Grand Rounds. Today is sort of interesting, and I think we all talk all the time about individual patient cases, but we really don't often get the opportunity to talk about all the things sort of outside of patient care that we're doing. So, we've really had a very full year full of a lot of uphill challenges that we've tried to tackle. And so we'll share some of those successes with you. And then really this will kind of be the Lindsay and Zach show, where they're going to talk to you about some of the new things that we're trying to launch and some of the new agents that I've been using more recently that you may have seen. So I'm not sure if anybody's heard to begin with, but apparently the Joint Commission is going to show up here any day, and maybe even Monday. So I thought I'd start by talking a little bit about that. I'll get into a little bit more detail in a few minutes. But you may or may not know that last year, actually, for the first time, the Joint Commission now has standards for antimicrobial stewardship within the medication management standard. And so we've worked very diligently for a long time to try to prepare for that. So I'll talk to you a little bit about that in a minute. The other thing we've been continuing to do this fiscal year is continued work on the C. diff coalition, which Sean McCullough introduced to you in his PGY1 seminar very nicely. And that work has really continued, and I'll kind of share a couple of the big learnings that we've had from that along the way. One of those was the fact that it was something really not that we didn't understand, but something that really became important as we did this work, which is that traditionally we really haven't had a great way to understand how we use antibiotics here at UVA globally and over time. And it turns out that through the National Healthcare Safety Network, through the CDC, they now have a means for us to understand how we use antibiotics by reporting what we do to them and then getting some information back. And so I'll talk to you a little bit about that new metric that they've developed and how we might think we could use it going forward. The other thing we learned a little bit from the C. diff coalition was, again, not a huge surprise, but we probably have some opportunities to standardize the way we treat some of the more common infections, and so Lindsay will go through a lot of that for you. And then lastly, no ID talk would be complete without doom and gloom, skull and crossbones, and so I have just a little taste of that for you. And of course, you all probably recognize that we have not gotten rid of all resistant organisms, but the good news is that we have a couple of new options to help tackle those that we maybe didn't have before, and so Zach will talk to you a little bit about that. And so, some days I think we all kind of feel like this. I sort of alluded to this earlier. You take on challenges, you're not sure if you're going to get there. And I think for the first time we really feel like with some of these really hard things that we're actually kind of reaching closer to the summit than we thought we could before. It can be pretty exhausted, but at least we're kind of doing it together. So objectives today, I'm going to go through some of just briefly, the regulatory requirements related to antibiotic stewardship, what happens if you're stopped in the hall in a tracer, for example, a little bit about some of the stewardship-related initiatives that come out of that, and then as I mentioned, Lindsay's going to tackle sort of standardizing a common infection, and today it's going to be HAP, VAP, and sort of choosing antibiotics and some of the management surrounding that, and then Zach will sort of go into, what happens if you have some really scary resistant organisms and what new options do we have in that setting. So to begin with the Joint Commission standards, this is how they're written. So these were effective as of January 1st of 2017. And I'll just highlight a couple of these things for you. And the first is that leaders establish stewardship as a priority. And I really feel like in recent months and a couple years since this has come out, we really are getting that support. And that's allowed us to do a lot of this great work that I'll be speaking to you about today. And then number two is going to be really important if you get stopped in the hall. And so that is that we educate our staff. And so you may remember, if you've been new to the institution recently, we do live education upon hire. You may have seen a CBL pop up in net learning related to stewardship that you've done, and that's new to fulfill the requirement that we do education not only upon hire but annually thereafter. So that'll be a new initiative going forward. And we also talk to you about resistance. We're doing that today, other new initiatives. And we also post our annual antibiograms, and they're available to everyone, and that constitutes education, so I've heard, through the Room and Mill with Joint Commission as well. The meat of the standards are meeting the what are referred to as the CDC core elements of a stewardship program, and these are shown on the left. And I think there are a lot of these things we've been doing well for a long time, particularly when we talk about care at the bedside. But as I alluded to earlier, we really haven't had a great way of tracking our antibiotic use, tracking how we treat individual infections, reporting that back, educating on that. And I think right now we're in a position to kind of do that much, much better, perhaps even for the first time. So assessment question 1, again, this is vital for what may happen next week or maybe the following week or maybe the following week. So you're stopped in the hall by representatives from the Joint Commission during a tracer. They ask, well, how are you educated about antibiotic resistance and ordering and monitoring and so forth? And so which of the following could be appropriate? Live education upon hire, maybe a CBL that you have to do every year. Antibiograms are available for you. I just went to some Grand Rounds presentation where they talked about kind of some of this stuff, or maybe all of those things. Great, so you have some tools at your disposal should you be the lucky one. Okay, so just very briefly a little bit about the C. diff coalition. Again, you may have heard Sean speak about this last year very eloquently. But when you look at sort of our rates, and this is an incident rate, cases per 1,000 patient days, and if you look along the x-axis, you'll see when in time we were, and our benchmark is going to be less than or equal to 0.8. And you can see before we started our work in the last quarter of 16, we were always seemed to be above 1, and we couldn't really make much motion. And then we did some interventions, including improving the way we order, think about the diagnosis, the way we order tests, and also just greater visibility around the disease. Going through cases all the time has brought our rate down. And we reviewed about 166 cases from then until when we last counted in January. And in looking at all of those cases, almost 40% of cases, there was some sort of antibiotic use opportunity for improvement that we identified. And so, in thinking about that, again, going back to the idea that we're sort of haven't traditionally had a great way to report our antibiotic use, this is the metric I referred to before that comes out of NHSN, which is called the SAR, and you may hear more about this as we teach you more about it in the coming months. But it stands for the Standardized Antibiotic Administration Ratio, and what that does is it compares how we use antibiotics to how a group of like institutions or like units use antibiotics. So if we use them all the same, the ratio is 1. If we use more, it's above 1. If we use less, then it's less than 1. And so those are some of the numbers that we may get back based on certain antibiotics, certain units in the hospital. But what's interesting about it is that this number isn't necessarily well understood yet. And so our hope is that we can partner with the CDC to evaluate what these numbers mean and sort of contribute to that scientific understanding. And just recently we had some of our numerator data available, and so these are use of some select antibiotics I thought you might find interesting. These happen to be our top 4 used in the treatment of nosocomial infection. These are days of therapy on the x-axis and unit on the y. I don't know what these mean. You can look and see who's at the top and who's at the bottom. Some surprises, maybe not some surprises. Again, we would have to look and, they may be a signal, maybe a place we could go look, but, I'm not going to make any commentary about anything you see here now. But the important point is we have data and we can find ways to look into optimizing antibiotic use. And then as I mentioned, the other thing that came out of the C. diff coalition was thinking about how we treat different infections. And when we looked at the different kinds of antibiotic use problems that we found, there weren't a lot of patterns, but one was how we manage HAP VAP. And so we then developed an institutional guideline to deal with that. So with that brings us to our first case. This is a case we saw in TCV. And a 72-year-old with several medical problems who was post-op day 6 from a 3-vessel cabbage. The only prior antibiotic use was peri-operative cefazolin. And on ventilator day 7, he developed fever to 38.7. Respiratory therapy reports increasing thick purulent secretions. You can see vitals and increasing FiO2. A leukocytosis, and a negative MRSA PCR prior to surgery. A new infiltrate was noted on chest x-ray, purulent secretions were sent for culture, and of course antibiotics were started. But which antibiotics to use is interesting, and if you kind of hear people talk about it throughout the halls, and I always like to Google things when I'm preparing for talks, and so there's Vosin, you guys have used that before. And it turns out you can actually purchase this brand name, which I didn't realize before, so this is the ad for if anybody's interested in doing that. Also, if you go to YouTube and look up Vancomycin, the pharmaceutical company that produces it has created a video that I highly recommend that you watch. I highly recommend that if you have students learning about stewardship that they watch it, or if you just want a break from all the madness out there, it's a pretty good listen. And if you believe the internet people, then this may be another option as well. So it turns out our guideline is posted for you already, and I'll hand it over to Lindsay, who's going to go through some of the most important elements of it.
Thanks, Heather. Hey, everybody. Before I get started, I'd just like to take a brief moment in memoriam of HCAP, which if any of you were here for my PGY2 seminar, this serves as my I told you so moment, because this is one of the previously thought of clinical entities in the prior guidelines that has been removed. And so that's just one of the changes to the recently, or 2016 IDSA guidelines that came out, where this is no longer talked about, and so it's really the focus on HAP, VAP now. And I'll talk about some other changes as we go through. But really, as Heather mentioned, we have a new institutional guideline, and so my focus is going to be on where our guidelines fall in comparison to some of the national guidelines. I'm going to do that by walking through a document called the Guideline at a Glance, which is available for your reference on the clinical portal. And I'm not going to focus a lot on diagnosis of pneumonia, but except to point out a few points. And so if you have a patient that you have a suspicion has pneumonia, the first thing I wanted to highlight was that in our institutional guideline, we do encourage the use of the CPIS score, which is something you'll note is a difference from the IDSA recommendations. And I'm not going to go into detail about that, but more information is available for you on the full document. And so just to highlight here that this only applies to patients that develop pneumonia while hospitalized. And so if that isn't your patient, you should reference our soon-to-be approved and upcoming community acquired pneumonia guidelines, but if it is your patient, we'll keep going and get some more information. So we want to get some microbiology. And one of the things I also want to point out here, and we'll spend some time talking about in just a little bit, is the use of the MRSA Surveillance PCR, which we have recommended to do if it hasn't been done in the last 72 hours. And that is also a little bit of a divergence from the IDSA guideline, and we'll talk about that. Where I'll focus the bulk of my portion of our talk today is on how to choose the correct empiric therapy for our patients. And so just as a really brief review, no surprises here, but just looking at what is the microbiology of VAP and HAP. And so this column here showing VAP is data that was reported from multiple U.S. hospitals, so the CDC over a period of 3 years from 2011 to 2014. And the takeaway here is that Enterobacteriaceae makes up about a third of the cause of our VAP. And then you can see that's followed by Pseudomonas at 17%, and just under a quarter is Staph aureus, but really only about 10% of that is methicillin resistant. And so trying to figure out which patients you need to empirically cover for that is part of what we'll talk about. And again, no surprises, the microbiology in CAP is notably very different. And this is just a review of literature just to show, since most of the data that we have is in VAP, we want to point out that the microbiology in HAP is very similar. So I just wanted to take a moment to point out that I think everybody's aware that most national guidelines recommend a lot of dual gram-negative therapy and anti-MRSA therapy, but they also emphasize that hospitals should generate antibiograms, and they should use the data from the antibiogram to decrease the unnecessary use of those agents when possible. So what do they specifically recommend for gram-negative coverage? They suggest 2 anti-pseudomonal antibiotics from different classes for empiric treatment if patients have any of the following. And I have noted here that this is considered a weak recommendation in the guidelines. So for VAP, they specify units where more than 10% of gram-negative isolates are resistant to an agent being considered for monotherapy. They also look for, they talk about risk factors for Pseudomonas or other gram-negative infection. And they specify prior IV antibiotic use within 90 days or structural lung disease like bronchiectasis or cystic fibrosis. And then for HAP, again, we see this risk factor for Pseudomonas or gram-negatives. And then what they're pointing out here is this high risk for mortality. So these are really our HAP patients that are going to be treated in the ICU. And so I want to look a little bit here. This is institutional data from our 2016 antibiogram. Note that this is not specific to respiratory sources, but it's all sources that had at least 10 isolates. And what you'll see here is that we actually have pretty high susceptibility rates for a lot of our anti-pseudomonal beta-lactam agents. Probably the one here that is, the more concerning would be the Piptazo in the ICU, and that's just a little bit lower at 79% for 2016. And as Heather recently mentioned, we are going to be visited by Joint Commission any day, and so this serves as part of your education. The antibiograms exist, and they can be found at the link shown at the bottom of your screen. So going back to this, national guidelines do suggest them to use 2 drugs in most patients, but in general, this isn't our approach at UVA. And that's for a number of reasons. This topic could be an entire hour-long presentation by itself. And so to try to summarize all of that in one slide, the ideal scenario is that your empiric therapy is active against your eventual pathogen, and that is the main reason for recommending dual gram-negative therapy to begin with. We know because of high rates of resistance that fluoroquinolones generally don't add to the empiric spectrum, and we're all very familiar with the toxicity profile of aminoglycosides with nephrotoxicity and ototoxicity, and we would like to avoid that whenever possible. And lastly, and most importantly, for the data that do exist, the clinical outcomes haven't shown to be better if the single drug is active on its own. And that's evidenced in this prospective observational multi-center cohort study that was conducted in 4 academic medical centers in the U.S. in response to the prior iteration of the guidelines that were released in 2005. And so what I want to point out is that what they did in this study was they looked at patients who received guideline-compliant therapy versus guideline-non-compliant therapy, and you'll note here that non-compliance was driven largely by the lack of that second anti-pseudomonal agent. And so what I want to point out here is that at day 28, not only did patients with guideline-compliant treatment not do better, significantly so, they actually did worse in this study. And I will note that there were more patients with severe sepsis in the compliant treatment group, and so that probably had some more impact on mortality seen in this study, but they still didn't do better with compliant treatment. And even when they did a sub-analysis of patients only with pseudomonal infections, they still didn't find a difference in mortality between compliant versus non-compliant treatment. So who does need to be treated for multi-drug resistant gram-negative organisms at UVA? So similar to the national guidelines, they do talk about the prior receipt of IV antibiotics in the last 90 days. We tried to expand on that by saying it should be a full course, but we note that there's more study needed there. So not all beta-lactam agents are created equal, and so if you get 6 weeks of IV penicillin, it's probably not going to confer the same risk of multi-drug resistance that 3 weeks of meropenem would, for example. But we have to start somewhere, and we have to put something in there. So, and then again, as previously noted, structural lung disease does confer a higher risk of pseudomonal pneumonia, and so those patients might benefit from an empiric second anti-pseudomonal agent. That should ideally be guided by past microbiology, but at UVA, an aminoglycoside is more likely to be the active second agent, and according to our antibiogram, tobramycin is the most active agent when compared to gentamicin. And then I'm not going to go too much into number 3 here, colonization with the late generation cephalosporin gram-negative pathogen. I'm going to let Zach talk a little bit more about that, but sometimes we have really complex patients that require a little bit more alteration to their empiric therapy regimen, and we hopefully have some agents to help with that in the pipeline, or now available. So let's pivot a little bit and talk about MRSA. And so national guidelines suggest including an agent active against MRSA for empiric treatment if patients have any of the following. Again, this is a weak recommendation. In VAP, they talk about units with 10 to 20% of isolates having methicillin resistance. In HAP, they just clarify over 20%. And then they talk again about prior IV antibiotic use within 90 days. And then for HAP, the patients that would be treated again in our ICUs, those are that are higher risk for mortality. Oh, I do want to also point out here that the guidelines talk a little bit about prior detection of MRSA in clinical cultures or in surveillance screening as a potential risk factor for development of a subsequent MRSA infection. But we know that the positive predictive value of MRSA in surveillance cultures has been found to be really low, like less than 40% in most cases. And so that was not something that was added into the guideline as a risk factor. However, I also want to point out that, in fact, this is the only thing that they say at all about the MRSA surveillance use in the IDSA guidelines. And so they really focus on its use for thinking of it as a risk factor. They don't talk about it for use as a useful tool for de-escalation, which is where I think most of the interest in that tool is in general. And so they only cite 3 studies, all of which are a little bit older. You might be familiar with some of these, so I'll just briefly review them. Again, this could be an hour-long lecture on its own. So the first study was all comers with MRSA cultures, so it isn't specific to pneumonias. But they had patients across the hospital. It wasn't just nosocomial infections. They did use a really tight cutoff of 24 hours, but they had a really high negative predictive value for all comers that had positive MRSA in their cultures. But the things I want to point out from this study were that they did have some false negatives in their respiratory isolates that had preceding negative PCRs, but they did note that their false negative rate wasn't affected by antecedent anti-MRSA therapy. And I think that's important to note because I personally have had questions about whether or not if your patient got a couple doses of VANC the day before they had their PCR obtained, like, do you have to worry that that might be a false negative? But everything that's been reported would suggest that vancomycin would be a weak agent for decolonization and that it's probably not going to eradicate nasal colonization in that time period. The other really well-known study, and the only prospective one that I could find, was from Barnes-Jewish Hospital in 2010, and I think this is the study that leads to the most pause when we talk about using as a useful tool for MRSA therapy de-escalation, because they did report a lower negative predictive value. When you look at it specifically for lower respiratory tract infections, it was around 85%. But the things that are important here are that they did this in a single medical ICU of 19 beds, and they had a really high colonization and infection rate in the study, and they also included bloodstream infections in their review. It's kind of hard to tease out some of the math when reading through it, but it is just something we have to acknowledge is out there. I don't think it's been really repeated in subsequent studies, but again, it's the only prospective one out there. Lastly, I won't belabor this one, but the other one that a lot of people reference because it has such a high negative predictive value was a study by Dangerfield and colleagues out of the Mayo Clinic in 2014, but this is really not applicable to this patient population because it was mostly CAP and HCAP. Okay, so because there is such an interest in using this for de-escalation purposes, there have been a lot of new studies published since even the guideline came out in 2016, and I don't really have time to go over all of them here, but suffice it to say that they all have limitations and significant methodological differences, but across the board, despite that, they all consistently have found a really high negative predictive value, even in ones that look at nosocomial pneumonia, even the ones that look at ICU patients, and so it's probably a pretty useful tool and one that we likely can't ignore. And so, because they have limitations in the studies, we wanted to know what was going on at UVA. Since we were going to recommend it in our guideline. And so I did, a very brief review. This was a very quick amount of work in like 2 days over the summer. But I looked at our first clinical isolate of MRSA from non-cystic fibrosis respiratory cultures. I looked at adult patients over an 18-month period in the last couple of years. I found 62 patients that had MRSA positive cultures that also had a preceding surveillance PCR. So at first it was a little concerning because 22% of them, like 13 patients, had an antecedent negative PCR and then went on to develop a positive MRSA culture. But there was no time cutoff, and most of the ones that you just saw had at least 7 days, if not a more stringent cutoff. And so when I narrowed that to 7 days, it was 3 patients, so about 5%. And then if you did 48 hours, it was 1 patient. And so to be on the more conservative side, we went with a time period of 72 hours or 3 days. And as Heather mentioned recently, we just got this new data, or the ability to look at institutional data at this level. But you will note that vancomycin is one of our most frequently used nosocomial antibiotics. And again, like she said, we don't really know what that means yet, but it does warrant further investigation, and maybe this will be a useful tool to help optimize some of that therapy going forward. Okay, so what did we actually recommend for empiric treatment in our ICUs? So here you'll notice, and if you remember on our antibiograms, piperacillin tazobactam was a little bit lower susceptibility rate in our ICU, so we went with cefepime as our preferred agent. We went with the higher dose here, and I've bolded it so that you can see there's a subnote, which for all of you that are going to be reviewing these, we have volunteered you to do a review in 24 hours. And because we don't think that the higher dose is really going to be necessary for a lot of the patients, but we don't want to miss anybody either up front. And so we've put some caveats in here for when the higher dose of 2 grams every 48 hours is likely appropriate. And then otherwise they can likely be decreased to the dose of 1 gram Q8. Here you'll also note that we're recommending empiric vancomycin for all patients admitted to ICUs with concern for HAP or VAP. And then if they have those pre-specified risk factors for gram-negative resistant organisms with or without tobramycin. And that differs from the recommendations on our acute care wards. Here you can see cefepime or piperacillin tazobactam are appropriate choices. Cefepime is at the lower dose here. Piperacillin tazobactam is at the higher recommended dose of 4.5 Q6, and then with or without vancomycin based on a patient's risk factors, which we also have a footnote here that I neglected to bold with IV antimicrobial therapy in the preceding 90 days, or we did specify a history of infection or colonization with MRSA. Okay, so assessment question number 2, and this should be pretty easy. Back to the patient that Heather introduced to us earlier. He's post-op day 6 for McCabbage, and he's on ventilator day 7. His last MRSA PCR was negative, but it was about 7 days ago. What empiric therapy do you want to recommend for this patient? Just shout it out if you want. 3? Okay, great job. And so here, number 1 would really be somewhat better coverage for CAP, although I don't think that's the dosing that we'll be recommending. Cipro, 750 BIDs, that would be, we've already talked about why fluoroquinolone wouldn't be your first choice, and not as monotherapy there. And then meropenem plus daptomycin, a lot of problems with that one, most notably that you wouldn't want to use daptomycin in any patient with concern for pneumonia, but everybody knows that. Okay, and then later you did get that repeat MRSA PCR and it came back negative. Your sputum culture is pending, but you have this showing on your gram stain, so 3+ white cells and 2+ gram-negative rods. Would you want to make any changes at this point? We'll assume your patient's also kind of clinically improving and doing fairly well. Yeah, so that would probably be our recommendation here. We're saying in general, if you have a repeat PCR within 72 hours and it's negative, most of the time those patients are not going to need empiric vancomycin continued. Okay, and then it's about 48 or 72 hours later, and we're really emphasizing here that it's important to take an antibiotic timeout, the point of which is to look for culture data and assess your patient's clinical response and see how they're improving. If they are improving and you have positive cultures, we would recommend that you de-escalate your antibiotics to treat the cultured organisms. And there is some additional guidance that I'm not going to review today for the sake of time on what the preferred agents would be depending on what's cultured. If your patient isn't improving, those might be opportunities to adjust your antibiotics or repeat cultures, consider some other source of infection, and maybe get an ID consult involved. Okay, so going back to the guidelines, I just like the specific language that they also recommend short-course antibiotic therapy for most patients, independent of microbial etiology, as well as antibiotic de-escalation. And so I'll end with this little piece of information about the shorter course, which I think most of you will recognize is a deviation from the previous guideline that suggested a longer course of therapy for patients with some non-lactose fermenting gram-negative rod pneumonia. And a lot of that was driven by the subgroup analysis in the classic 8 versus 15 days of therapy paper that showed a higher rate of recurrent pneumonias in that subset. However, there have been some subsequent systematic reviews and meta-analyses, of which this is one, where they looked at 4 different randomized trials, and they found, no overall difference in mortality, and they also found no mortality when they looked specifically at patients that had the non-fermentive gram-negative bacteria as the causative pathogen, and most of the studies have also really not found any higher risk of recurrent pneumonia to point out. So that's really all I'm going to talk about today. I got the easy part because really my patient was a lot more straightforward, sort of a textbook example of a HAP-VAP case that presumably went well. He got therapy for 7 days and then we stopped. And so I'm going to hand it over to Zach to talk about another case in our TCV unit that didn't maybe go as well and was a lot more complicated, and what you can do with that.
So as Lindsay mentioned, we'd now be talking about some of the treatment options we have for more multi-drug resistant gram-negative organisms. And before I start going through the actual treatment, I thought we could start with a patient case. So many of you have probably assisted with this patient at some point as they were here for several months. So this is a 68-year-old male with a history of pulmonary fibrosis. He had a lung transplant that was complicated by allograft failure and had an immediate redo 2 days later. He had a complicated post-op course including ECMO, CRRT, and antibacterials for multiple episodes of HAP and VAP. So on hospital day 9, this is the Pseudomonas isolate that was obtained from the BAL. So as you can see from here, this is a pretty friendly Pseudomonas isolate other than mildly elevated MICs to like cefepime, meropenem, and piptazo. So appropriately, he received cefepime for around 8 days for the treatment of this presumed VAP with Pseudomonas. Fast forwarding several weeks later, this is the pleural fluid that was isolated on day 42 when he was thought to have extrapulmonary infectious complications. So as you can see, the Pseudomonas now looks a little different. There's intermediate susceptibility now to cefepime and piptazo. At the same time, he also had this Serratia isolated that is relatively friendly and susceptible to the panel of antibiotics that were tested. So it was elected to treat this patient with meropenem. He did get a very long course of 24 days. That was complicated by some source control issues at the time. After a 111-day admission, he was then discharged to Health South and came back 9 days later with hypotension. Blood cultures were obtained in the ED on admission, and this is the isolate that was found in his blood cultures. So as you can see, this is a Serratia isolate that has carbapenem resistance now. And so the question is, what is the best treatment option to manage this patient? So we'll come back to this case at some point and talk about some of these newer options. So moving forward, before I talk about the individual agents, I thought we could talk about drug resistance in the U.S. in general. So if we look at Klebsiella in the U.S., and this is a chart from 1999 to 2014, I think it's important to focus on the carbapenems, which are the lime green line here. And it wasn't until about 2007 until you started seeing this increasing resistance with carbapenems, and now we're at about the 10% mark for Klebsiella, and this is for Pseudomonas. And carbapenem resistance among Pseudomonas has always been somewhat of an issue, and that's shown here with the pink line. And right now we're at about 20% overall in the United States for carbapenem resistance among Pseudomonas isolates. So these are the 3 drugs that I plan to focus on: ceftolozane, tazo, ceftazidime, avibactam, and meropenem, vaporbactam. And it's important to note these are all new antimicrobials, but they're not necessarily novel. They're not new mechanisms of actions, but really different takes on antimicrobials that have already previously been approved, or either adding a new beta-lactamase inhibitor. So ceftolozane tazobactam is not on formulary here, but we can use it and requires an ID consult. And it's approved for complicated UTIs and intra-abdominal infections, whereas ceftaz AV and meropenem vaporbactam are both approved on formulary and both also require an ID consult. It's worth noting that ceftazidime avibactam now has HAP VAP approval, and that happened within the last week, and I'll talk about some of the studies that led to that approval. And these antibiotics can be very confusing, even among IDs sometimes, just because they are quite detailed in how they work. So all of these have a beta-lactamase inhibitor as part of their component, so I thought we should quickly review beta-lactamase in general. So there's 4 different AMBLR classes that we can discuss, which are A, B, C, and D. So among class A, all of you are probably familiar with non-ESBL producing beta-lactamase, which hydrolyze the early cephalosporins and penicillins. All of our beta-lactamase inhibitors we'll discuss today do inhibit non-ESBL. Among ESBLs, all of them inhibit that as well. There's some controversy about how well tazobactam performs against these ESBLs. And what's most important are the KPCs, which of course hydrolyze carbapenems. And tazobactam has no activity against KPC, whereas avibactam and vaporbactam are some of these newer beta-lactamase inhibitors that can inhibit KPC. None of these have activity against metallo-beta-lactamases such as NDMs, which are relatively uncommon in the U.S. but seen in other parts of the world, especially like India. AMP-C, as many of you are probably familiar with, are class C, and then OXA48, which is relatively rare, is class D, which also can hydrolyze carbapenems, and avibactam is the only one that's been shown to have any activity against OXA48. So that was the quick review. Now we'll look more specifically at ceftolozane tazobactam. So ceftolozane itself is essentially ceftazidime with this added moiety here on the side, which confers anti-pseudomonal activity. So by itself, it is active against some of the TIM1 and SHIV1 class A beta-lactamases, but it is destroyed by ESBL and carbapentamases. And as I mentioned, it's this side chain that actually gives it enhanced activity against Pseudomonas by evading some of these efflux pumps, porn channel loss, and PBP modification. Tazobactam, as you all are familiar with, like in pip-tazo, it does add some activity against ESBL producers and minimal anaerobic activity, but it's important to remember you're not adding anything for pseudomonal activity by adding tazobactam. It's really the ceftolozane that is the new agent. So its spectrum activity and breakpoints, we've already discussed some of this. It has potent activity against some Enterobacteriaceae, but then some ESBL producers. And it is potent against Pseudomonas thanks to the ceftolozane component, and it is weak against KPC or metallo-beta-lactamase producing GNRs, most gram-positives, and then gram-negative anaerobes. I won't go through the exact MIC breakpoints, but these are in CLSI, and you can see just for your reference what the breakpoints are when using this drug. As I mentioned, ceftolozane tazo is really designed for these carbapenem-resistant Pseudomonas isolates. So this is a study that included a couple thousand, or 1,971 isolates, and these are, I've broken these down by the percent susceptibility by all the isolates, the multi-drug resistance, and then those that are extensively drug resistant. So these are other drugs compared to ceftazo, such as cefepime, meropenem, pip-tazo, levofloxacin, and colistin that all of you are probably familiar with using against Pseudomonas. But you can see that the ceftolozane tazobactam perform much better, especially against these XDR pathogens as compared to the others. Maybe not as compared to colistin, but we know colistin has its own host of problems by acting somewhat as a detergent against a cell wall and is very neurotoxic and also very difficult to dose. This is the dosing of ceftolozane tazobactam, more so for your reference, and there's one thing I want to point out. So if you look in the package insert, it is FDA approved for complicated intra-abdominal and then urinary tract infections, including pyelonephritis, and that dosing you'll find in the package insert is 1.5 Q8. But it is important to note there's an ongoing phase 3 trial where they're using ceftotazo in the treatment of HAP and VAP, and all of those patients are receiving 3 grams Q8, assuming they have normal renal function. And they're tolerating that dose fairly well, at least from the preliminary reports that have been released. So don't be surprised if you see ID recommend a 3 grams Q8, even in someone that doesn't necessarily have HAP and VAP. And this is more so why, due to the severity of illness, and we know patients can tolerate this dose. And this is the renal impairment creatinine clearance table to show how you could dose adjust. There's not much guidance with dosing the 3 grams Q8 in hemodialysis, and it's more so a patient-specific dose. So that's ceftolozane tazobactam that you can remember more so for Pseudomonas, and now ceftazidime avibactam is more so for our KPC Enterobacteriaceae isolate. So ceftazidime, as most of you are familiar, is a third-generation cephalosporin, and it's easy to remember that it's similar to ceftriaxone with its gram-negative activity, except adding pseudomonal activity, and of course has poor gram-positive activity. Avibactam is this new beta-lactamase inhibitor that inhibits class A and class C beta-lactamase and also some class D. So it's a potent inhibitor of KPC and AMP-C, and that's what makes this drug pretty interesting. And it causes 4 to 10,024-fold MIC reduction for most Enterobacteriaceae. And it's worth noting it can improve the activity of ceftazidime against some pseudomonal isolates, and that really depends on the mechanism of resistance, and that's a little beyond this presentation. So the spectrum of activity and the breakpoints for ceftazidime avibactam, we know it's potent against Enterobacteriaceae and more importantly these KPC-producing organisms, and sometimes it can be potent against Pseudomonas. It is weak against gram-positives, some metallo-beta-lactamases, and as well as anaerobes. And these are the susceptibility breakpoints for ceftaz-AV. Again, this is not actually published in CLSI. This is from the package insert, and these are the FDA breakpoints of which is essentially less than or equal to 8 for susceptible and greater than or equal to 16 is considered resistant. So as I mentioned, ceftaz-avibactam is great against KPC producers. So this is a study that actually involved like 20,000 isolates or something, but only 120 of these were actually KPC producing isolates. So those are the ones I chose to represent here today. So as you can see, the green shows the susceptible, yellow is intermediate, and red are the resistant isolates. So ceftaz avibactam actually performed at like 97.5% susceptibility to all of these KPC isolates, and the very few that it was resistant to were isolates that were super rare and you typically wouldn't find here in the U.S. And you can see how much better it performs versus the other typical gram-negative antimicrobials that we may consider using. So since Lindsay mentioned HAP and VAP, can we use ceftazidime avibactam for HAP and VAP? So the REPROVE study is actually a study that was done comparing ceftazidime avibactam to meropenem in the treatment of HAP-VAP. So it involved 23 countries giving patients 7 to 14 days of ceftazidime avibactam versus meropenem, looking at clinical cure at 21 to 35 days after they were randomized. They had over 500 patients, and you can see here that it does slightly favor meropenem in the clinical cure rate. However, there's no statistical difference between this, and this is actually what gave the FDA approval to Allergan for the ceftazidime avibactam for HAP and VAP. And as you can see, that actually happened on February 2nd, so it was relatively recent. I think more importantly, if we look at that study is focusing, this is actually in the supplementary appendix, but if you look more closely at Enterobacteriaceae and Pseudomonas, with Enterobacteriaceae at the top and Pseudomonas at the bottom, and comparing the difference of what avibactam gives you and with the ceftazidime. So if you focus on the top in part A, as you can see, the hyphenated line represents the, separates susceptible from resistant. And you can see that the MICs are drastically lowered when you add avibactam to ceftazidime in the treatment of Enterobacteriaceae, which is what you would imagine. But with Pseudomonas, you don't see that much of a shift. MIC 90 does go from 32 to 8. So depending on the mechanism of resistance, avibactam can help you. But again, this sort of brings home the point that ceftazidime avibactam's real place in therapy is for these KPC Enterobacteriaceae. As we've seen with the ceftaz, this is ceftaz avibactam dosing, and this one's easier to remember because the standard dose among any of these infectious complications are 2.5 grams q 8 hours, and it does have FDA approval as mentioned for HAP and VAP as listed here, and these are, again for your reference, the renal dosing recommendations. Moving forward, lastly, we'll discuss meropenem vaporbactam. So all of you are probably familiar with meropenem just being anti-pseudomonal carbapenem, but now we've added this new beta-lactamase inhibitor, vaporbactam. So it's different in that it's a boronic acid beta-lactamase inhibitor, and it has activity against ESBL and KPC, sort of like we saw with avibactam, and also class C beta-lactamases. It does not inhibit class D or class B. So as you would imagine, this improves activity against Enterobacteriaceae, but it's important to note that you're not getting any added benefit against Pseudomonas. So again, another KPC drug that could have potential to cover Pseudomonas that is carbapenem susceptible. So how well does meropenem work against CRE? And this is the Tango 2 trial that actually granted or allowed meropenem vaporbactam to receive approval from the FDA. So they took patients with CRE, and interestingly, they took patients with multiple different infectious complications, as you see, UTIs, HAP, VAP, as well as bacteremia and intra-abdominal infections. So they randomized these patients to receive meropenem vaporbactam, or either whatever the best available therapy was, and they included 43 patients that had this CRE. And as you can see here, meropenem vaporbactam actually outperformed the best available therapy in all of these endpoints, in mortality as well as clinical cure at the end of therapy and as well as at the test of cure. So this is what allowed meropenem vaporbactam to be approved. So I know that's like these three drugs are easy to be confused. So I tried to make a chart here where you could at least see what the differences are. And this isn't necessarily perfect, but if you look at ceftolozane tazobactam, we know tazobactam is somewhat active against ESBLs, yet controversial. So it could potentially be used against ESBLs. However, it has no activity against KPC, hence the red color. It can be used against carbapenem-resistant Pseudomonas, being that ceftolozane is a novel compound that is less resistant to the resistant mechanisms of Pseudomonas. It has no activity against NDMs, most multidrug-resistant Acinetobacter or anaerobes. And then comparing ceftazidime, avibactam, and meropenem vaporbactam, both of those are great drugs for ESBL and KPCs. Again, as I mentioned earlier, avibactam or ceftazidime avibactam can be used for some of these carbapenem-resistant Pseudomonas, depending on what their mechanism of resistance are. Meropenem vaporbactam as I mentioned as well, Vaporbactam doesn't add anything for carbapenem-resistant Pseudomonas, hence the red again here. And the difference from these others that you see here is that meropenem does have anaerobic coverage. So back to the patient case that we mentioned, this unfortunate gentleman that was readmitted 9 days later with hypotension and had this serratia. So looking at this susceptibility pattern, if you can see it, which of the following would be appropriate? Would you do fluoroquinolone plus meropenem, ceftazidime, avibactam, tigecycline, ceftolozane, tazo, or meropenem, vaporbactam? We have to remember this is a KPC isolate, so. Anyone? Well, I heard a B, but it's actually, you could do both of these. So this was before we had meropenem, vaporbactam even on formulary, and it wasn't tested. But as you can see, this is meropenem resistant, and so the organism is likely producing KPC. So you would not use tazobactam. You wouldn't use Cipro, Mero, both of those being resistant. Tigecycline for a host of reasons, but ceftazidime, AV, and meropenem vapor both could be useful for the treatment of this. So ceftazidime, avibactam was actually started empirically, and the patient responded well. 2 weeks later, he developed septic shock and Pseudomonas bacteremia, and his airway was colonized with serratia. So you can see these two were the latest isolates that were taken from this patient. So he was actually treated successfully from an infectious standpoint. But he was transitioned to comfort care for a variety of other reasons. So this is sort of a morbid ending to this case, but it is important to note that, or the silver lining here is that we do have drugs now that we can treat some of these more complicated patients with really multi-drug resistant organisms. So now I can pass it back to Heather to sort of summarize what we've discussed thus far.
So I think what we've learned today is, again, back to Joint Commission, who could show up any day. They provided standards and really has given us a lot of support and a lot of leverage to do things that we perhaps weren't as well positioned to do before, and I talked to you a little bit about that. And again, as a reminder, today you were educated about some of the things that we do in stewardship, about resistance, about some of our new initiatives, and they might ask you about that. Lindsay nicely went through our management of HAP VAP and our new institution-specific guideline, and really what we'd like to emphasize, and you can also ask Sarah about this, doing a 48 to 72 hour timeout when you're considering what to do with therapy when you have a little bit more information back, and really focusing on shorter durations. And that's really been a hot topic in ID for multiple different kinds of infections lately, where we're learning from new literature that less may be more. And using these new beta-lactams can be really tricky, and we're kind of learning as we go. And even some of the rules that you've learned today may not always apply, and that resistance can happen too. And so we're going to learn about these drugs together as we go forward. And then we all kind of felt bad about picking a real case that kind of had a sad ending. So we just want to highlight that ID isn't always so depressing. We've actually cured some people with these drugs too. And so with that, we'll welcome any questions you have. Thank you. All right, so easy stuff, right? So I think what's going to be exciting is pretty soon we'll have some unit-specific antibiotic use data for you, and we'll enjoy partnering with you to figure out what it means together and how to move forward and try to maybe generate some really exciting residency projects from it. All right, thanks everybody. Have a great weekend.